So second line therapy for metastatic pancreatic ductal adenocarcinoma. The treatment decision therapists who fail first line therapy are influenced by prior therapy received as well as patient related factors. Patient's condition factors like performance, comorbidities. For patients who failed this FOLFIRINOX but maintain adequate performance status, then we can give them an gemcitabine nab-paclitaxel is a good option. Again, FOLFIRINOX first, patient's PS is good, disease is progressing, we can go for gem nab-paclitaxel. Meeta and colleagues, they conducted multi-center phase 2. 30 patients who failed this FOLFIRINOX were treated with gem nab-paclitaxel. Overall response rate with this was 13%. OS 7 months, median PFS 3 months. So French NGO conducted prospective cohort of 57 patients of metastatic who failed this FOLFIRINOX and were treated with gem nab-paclitaxel as per the mPDAC protocol until disease progression, patient refusal, or unacceptable tolerability. Control rate 58%, median OS for 8 months, PFS 5 months. So patient with a poor PS, significant comorbidity, gemcitabine monotherapy. If patient is having severe comorbidities, not tolerating like poor PS, then we can go single agent gemcitabine. For those with a metastatic failed gemcitabine based regimen, 5-FU based regimen is alternative. So there is study Napoli 1. Benefit of non-nano liposomal irinotecan alone, 5-FU alone with folinic acid. 5-FU in patient with metastatic who progressed on gemcitabine based chemo. This has improved OS compared to 5 folinic acid. No difference in survival. More grade 3-4 adverse effect on combination chemo like diarrhea, vomiting, fatigue. So liposomal irinotecan received FDA approval as a second line therapy in the combination with 5-FU for patients who progressed on gemcitabine. This is important. Liposomal irinotecan with combination with 5-FU used as a second line agent. Now sequential chemo. Evidence suggests potential benefit of sequential exposure to multi-agent chemotherapy in the metastatic pancreatic ductal adenocarcinoma. FERGEM trial. Metastatic pancreatic ductal adenocarcinoma, good PS. Gemcitabine alone or FOLFIRI. So PFS, OS, they were improved who received alternating FOLFIRI and GemCis. For GEMAX, gem nab-paclitaxel or gem nab-paclitaxel 2 cycle followed by FOLFIRI 3 every 14 days of 2 months, sequencing repeating until disease progression. So gem followed by FOLFIRI or gem nab-paclitaxel followed by FOLFIRI. So this is sequential chemo. So PFS survival rate were higher in sequential arm. Grade 3-4 toxicity more common in the sequential arm. So pancreatic ductal treated with either FOLFIRINOX, gem nab-paclitaxel in first or second line setting to examine association between the treatment and overall survival. So median OS patients treated with FOLFIRINOX followed by gem nab-paclitaxel was 13 months compared to 13.8 months patient treated gem nab-paclitaxel followed by FOLFIRINOX. Any sequence can be used. And maintenance chemo, GIT SG adjuvant chemoradiotherapy group. Postoperative radiation who received post-op RT in conjunction with 5-FU bolus. Undergo resection completed all adjuvant who received maintenance capecitabine. Maintenance capecitabine demonstrated median OS of 48 months compared to 22 months who did not receive maintenance therapy. Then Panomox Prodige 35. 6 months of folfirinox, 4 months folfirinox followed by maintenance 5-FU leucovorin. Alternating regimen of folfiri-3 and gemcitabine every 2 months until progression. Data suggests that maintenance 5-FU leucovorin is an option of patients with metastatic pancreatic ductal adenocarcinoma who do not progress after 4 months of folfirinox. And another study is POLO trial, BRCA metastatic pancreatic ductal adenocarcinoma, platinum-based chemo, and then maintenance olaparib 300 mg twice daily. Olaparib would have improved PFS, improvement in OS, Apollo study, efficacy of maintenance olaparib. In patient with BRCA1-2, PALB2 mutated pancreatic and actively accruing. In precision therapy for metastatic adenocarcinoma. So predictive biomarkers to match specific treatment to individuals would be a significant advance in step towards personalized treatment. 25% pancreatic activation, actionable alteration defined by existence of evidence suggesting potential benefit from specific therapy. Genes that for DNA damage response pathway including immune checkpoint inhibitors, mismatch repair deficiency, tropomyosin receptor kinase inhibitor, BRAF mutation PARP inhibitors. Most impactful mutation therapeutics are likely NTRK mutation with attractanib and PD-1 inhibitor to treat microsatellite unstable patients. So 8 patients, the mutation in NTRK genes causing microsatellite instability are extremely rare. Then Pishwari and colleague, benefit of targeted therapies for pancreatic ductal adenocarcinoma. So routine detailed molecular profiling of patient provide benefit. It is difficult to understand how 1 year survival advantage could be achieved with precision therapy. Most common mutation targeted therapy, BRCA mutation PARP inhibitor, did not improve overall survival in a randomized trial. And monitoring response to therapy. Multiple active multi-agent regimens available to treat pancreatic ductal adenocarcinoma. Patients increasingly have second-line options after first-line therapy fails. And it is important to oncologists to closely monitor patients' signs of progression. Patients typically have weak laboratory tests and are seen bi-weekly, monthly by medical oncologists to assess for the signs of treatment toxicity. So imaging with CT MRI assessed every 8 to 12 weeks using RECIST criteria as a guideline. CT MRI RECIST criteria. C99 level is more to monitor similar fashion. Greatest decreasing being associated with the best outcome. CA, CA125, not FDA approved biomarkers. They may be helpful to monitor response to therapy, particularly in patients who do not express CA99 due to Levis antigen morphism, polymorphism variability. And so liquid biopsies testing genomic mutation, RNA transcript, ctDNA. They may be informed treatment monitoring, and when faced with the patient with clear disease progression, it is important overall condition of the patient like comorbidities, performance status. They are also taken into decision. ECOG PS more than 3, they have limited survival, do not benefit from any additional aggressive therapy. And palliation of symptoms, how can we do? Cure is uncommon in the setting of pancreatic ductal adenocarcinoma, even in localized disease. So goal is achieving best possible quality of life. So palliation of symptom is essential. And metabolic burden, treatment toxicity, mechanical obstruction, malnutrition is multifactorial, combination of cancer, cachexia, pancreatic insufficiency. So pancreatic enzyme replacement, that should be considered in patient with clinical evidence of malabsorption. Aggressive pain management like minimal invasive intervention, celiac plexus, neurolysis, endoscopic percutaneous, thromboembolic event, biliary obstruction, gastric outlet obstruction, or active surveillance, psychological issue, symptom deterioration, anti-tumor directed therapy, 1 to 4% mortality related to systemic treatment. It is essential to have a direct discussion with the patient and families for supporting care when appropriate, and alternative management strategies to manage symptoms, including like music therapy, medical cannabis, acupuncture, meditation, massage. Future direction, management of pancreatic ductal adenocarcinoma evolved over the past 50 years. So in 1970, there was no effective treatment existed except surgery. 1980 to 2000, major surgical outcome for pancreatic duodenectomy improved dramatically, allowing safe treatment in the early stage pancreatic and high volume centers. And over the past 20 years, there have been incremental improvement in the chemotherapy, more efficacious monotherapy. There have been also advancement in the understanding of the genetic and molecular basis of the pancreatic ductal adenocarcinoma. And there has been growing emphasis on the treatment sequences for localized disease, development of KRAS inhibitors, solid tumors is also one option. Clinical trials needs to propel pancreatic cancer research. 430 active clinical trials are going on, and 90% of this phase clinical trial failed to result approval of new therapies. So difficulty in identifying testing novel therapies. There exist racial, socio-demographic disparities. Most clinical trials do not report the enrolled race, ethnicity. So National Cancer Database clinical trial participants in the pancreatic found only 0.4%. They were enrolled. So 5% have been estimated. Numbers are exceptionally low. We must take to improve concern effort to improve trial enrollment whenever possible. Addressing the racial, socioeconomic, facility-based disparities are certainly areas of targeted intervention through physical, other healthcare providers, education, outreach, patient education, and partnership with community leaders. Has been continued emphasis on multi-institutional collaboration fostered by NCI. Opening door as much as possible for novel therapeutic strategies. And we hope that a significant advancement in the pancreatic cancer therapy will be reflected in future. So improvement in pancreatic cancer treatment over the past 2 decades include safe surgical treatment, safe radiotherapy, modest improvement in systemic therapy, combination treatments, modern multimodality including surgery for localized chemotherapy for most patients experience temporary disease control, and this disease is still lethal in most patients and survival beyond 2 years is still considered success. And due to incremental advance, patient number of long-term survivors have increased in recent years, yet the field still much progress left to achieve. Thank you.